This is Dr. Zabczynski. This presentation is from Chapter 39, Infectious Gastrointestinal Disorders in the Primary Care text. The topics covered here are gastroenteritis, hepatitis, and appendicitis. A few words about the GI tract and our immunity. The GI tract plays a major role in maintaining our health through immunity. Helpful bacteria are plentiful in our gut. The gut also produces immunoglobulins that protect against invading organisms. Sometimes these organisms can overwhelm the gut. Diarrhea that accompanies gastroenteritis is not the functional type of diarrhea that we see in the Rome 4 criteria. Functional diarrhea must be present for 8 weeks with loose or watery stools, but without predominant abdominal pain or bloating. So the definition of gastroenteritis is an inflammation of the stomach and intestine. It is often accompanied by anorexia, nausea and vomiting, and diarrhea. The gastroenteritis can be acute or chronic. Acute causes are typically bacteria, viruses, parasites, and injury to the bowel mucosa from poisons and or medications. Chronic causes of gastroenteritis are food allergies, food intolerances, stress, and lactase deficiency. This is a list of causative organisms that are typical. Bacterial, I have highlighted a few that are more common than others. But Campylobacter jejuni, Clostridium perfringens, Salmonella, and Staphylococcus are examples of common bacterial illnesses that can cause gastroenteritis. We're not leaving out these others because we certainly see a good bit of Clostridium difficile, but for this particular presentation, these are the ones we're going to focus on. We also have a number of viral organisms, rotavirus, which you can see in children but also adults, and the Norwalk virus, which is from the family of noroviruses and is the one that's implicated in cruise ship gastroenteritis. Additionally, we have protozoas such as Giardia, Entamoeba, and Cryptosporidium. The bacterial organisms account for 30 to 80% of acute gastroenteritis. These are important causes of morbidity in tropical areas and in travelers to high-risk areas. It's called traveler's diarrhea. Some of the areas of the world that are more prone for gastroenteritis from an infectious bacteria are Africa, Southeast Asia, developing countries in the Middle East, or Latin America. Clinical presentation. Patients often present with a variety of symptoms of varying degrees: nausea and vomiting, diarrhea, some may have fever, abdominal pain and cramping. They can also have accompanied symptoms such as fatigue, malaise, which is where they just don't feel good, anorexia, and borborygmi. Borborygmi is that gurgling, intensive movement of, or peristalsis in the abdomen. Profuse diarrhea can cause rectal burning and bloody stools from abrasions to the rectum. The description of the stool can give you a clue to the source of the infection. Voluminous stools point to a small bowel or proximal colon as the source of infection. Small stools and a sense of urgency suggest there's some sort of mucosal damage and inflammation from the pathogen. A frothy stool and a lot of gas suggest a malabsorption type syndrome. Some of these organisms, especially the protozoas, if they're in there long enough, they can cause damage to the lining of the intestines which causes malabsorption. Giardia is one of those. The history is very important. We need an exposure history. Have there been shared meals? Is anyone else sick? Did they attend a buffet or a picnic? Were they on a cruise ship? What about the drug history? Is there any indication of laxative abuse, which can certainly damage the intestinal mucosa? Alcohol use. Antibiotic history. Have they been on antibiotics recently, like within the last 6 weeks? Do they take supplements of any kind? Get a social history, sexual orientation, especially where people may be engaged in anal intercourse, and of course get a travel history. Once you've got a good history, let's take a good look at the patient. In general, how does the person look? Do they look ill? Or do they look fairly well? Focus your exam on signs of dehydration, especially with nausea and vomiting and diarrhea. What are the vital signs? Do they have a fever? Are they tachycardic? Do they show signs of hypotension, such as dizziness? Is their blood pressure low? These can be signs that the disease is severe. What is their skin turgor? Look at their mucous membranes around their mouth and see, are they dry or are they moist? These are really important signs of disease severity. Some diagnostics may be appropriate. For people with severe diarrhea, dehydration, fever of 101.3 or higher, you can order fecal leukocytes or white blood cells. The presence of fecal leukocytes may indicate an invasive pathogen, one that's well established, such as Shigella, Salmonella, or Campylobacter, Clostridium difficile, Yersinia, and E. coli. These are all really nasty bugs. For individuals with chronic diarrhea, the fecal leukocyte may actually suggest an inflammatory bowel disease, such as Crohn's disease or ulcerative colitis. Individuals who have severe diarrhea or bloody diarrhea, we should also get a stool culture. The culture may help us further identify Shigella, Salmonella, Campylobacter, Yersinia, or E. coli. You're going to hear those over and over again because they're common bacteria. If the stool culture is negative, but the person has persistent diarrhea, you can actually order a stool to examine for ova and parasites. Ova are eggs. So suspect parasites if the culture is negative. Another test that can be ordered is immunofluorescent antibody testing and diagnostic enzyme-linked immunoabsorbent assay, or ELISA for short. And this will help identify Giardia and Cryptosporidium. None of these have to be memorized. The thing is that you want to look at what the symptoms are, the severity of the symptoms, and then you can go through a process of ordering leukocytes, a culture, stools for ova and parasites in a very logical manner. The differentials are based on the chief complaint, the history, and the physical. You've got to ask, what can this be? Look for red flags. You want to rule out inflammatory bowel disease or any malignancies. You also want to be aware of risks for Clostridium difficile or C. diff. Anybody that's been on antibiotic in the recent past 6 weeks or so with persistent diarrhea very well could have C. diff. Other red flags include weight loss and bloody diarrhea. Bloody diarrhea has to be, you have to rule out inflammatory bowel disease and the Shiga toxin producing E. coli. This is found in certain areas and can cause terrible disease. The management of gastroenteritis begins with fluid repletion. This means replenishing fluid and electrolytes if necessary. Oral fluid replacement is preferred if it's tolerated. We especially have to make sure that children, elderly, and immunocompromised individuals are able to take in fluids and so they don't become severely dehydrated. For instance, recently a young child was seen with hand, foot, and mouth disease, and because of some ulcers in the mouth, became moderately dehydrated and would not take in oral fluids, was sent to the ER and received replacement fluids IV, and then was able to go home. So sometimes moderate to severe dehydration with hypotension or other symptoms, or if the person cannot take in the oral fluids, we need to send them out to the ER setting so that they can get fluid repletion. A diet needs to focus on boiled starches and additional salt if needed. Remember, people that are vomiting and have diarrhea are losing salts. There's no reason to avoid dairy. Sometimes they don't tolerate it very well, but if they can, dairy is okay. And we advance the diet as stools become more formed. Anti-motility drugs are helpful in severe diarrhea, and they work by slowing the intraluminal peristalsis and slowing the passage of fluid through the intestines, and this helps absorption of fluids and decreases the diarrhea. Some of the examples are bismuth subsalicylate, loperamide, and diphenoxylate with atropine. Now these are the generic names. Bismuth subsalicylate is actually Pepto-Bismol. So it's a good thing to know what the brand names are as well. So write those down for yourself. One thing to keep in mind is that these drugs that slow the motility of the intestine are not indicated for people that have dysentery. A patient that has dysentery often needs to shed the pathogen, and we don't want to slow that process. Empiric antibiotics can also be used. Empiric means that we are treating as if we know this person has a specific diagnosis. Because of the risk of C. diff, however, antibiotics are reserved for those with more severe disease. Fever of greater than 101.3, 6 or more stools per day, and dehydration. These people may have invasive bacterial infection with bloody or mucoid stools. If they're over 70 or immunocompromised, UpToDate says we treat them empirically. Traveler's diarrhea is another reason to treat, and the treatment for traveler's diarrhea is azithromycin 1 gram per day for 1 to 3 days. Fluoroquinolones were once readily prescribed for traveler's diarrhea, but they now have a black box warning and are no longer recommended. That means unless they're absolutely necessary, as in there's no other option. This section covers hepatitis. Hepatitis is an inflammation of the liver caused by a number of things. In this section, we're going to cover the viral causes: hepatitis A, B, C, D, and E. This slide is about epidemiology of these different viruses. The most common in our country are A, B, and C. D only occurs when a person has hepatitis B. So it's considered a co-infection, and E is pretty rare in our country. Hepatitis A is a single-stranded RNA virus. The risk factors for contracting this are crowded conditions. Think nursing homes, daycare centers, where people have a lot of contact with each other. Also, places that have poor sanitation. The transmission is oral, fecal, usually to contaminated food, water, or ice. Typical would be someone who is infected and with poor hand washing, who then handles the food at a restaurant or on a cruise ship. So the incubation period is anywhere from a month to 6 months. Persons often have flu-like symptoms. The good thing about hepatitis A is that a vaccine exists. People who are at risk for developing hepatitis A, or people who are traveling to third world countries where hepatitis A is endemic, the vaccine exists. Hepatitis B is a hepatinovirus. It has 8 different genotypes. The risk factors include men who have sex with men, IV drug use, and first generation immigrants, specifically from Southeast Asia, China, and the Middle East, and healthcare workers. Transmission is direct contact with infected blood products, and sexual contact. The incubation average is 12 to 14 weeks, but it can last as long as 6 months. Often the people have minor symptoms, or they may have none at all. A vaccine exists, and all newborns are vaccinated at the time of birth and at 30 days and then at 6 months. Chronic hepatitis B infection can occur when a person does not convert to an antibody, and with that comes the risk of hepatocellular carcinoma. Hepatitis C is a single-stranded RNA with 6 genotypes and probably 50 subtypes. The risk factors here are IV drug use, about 60%, transfusion and transplant before 1992, when the blood banks began screening for hepatitis C. Prior to that, it was called non-A, non-B hepatitis. Healthcare workers, and there is transmission from mother to newborn. The transmission is percutaneous exposure to blood and blood products. That's most common. Also tattoos and piercings, and as I said, mother to newborn. The incubation period, about 6 to 7 weeks. Again, there aren't a lot of symptoms here. There are antiviral drugs to cure hepatitis C, but there's no vaccine. How do we diagnose hepatitis? The diagnosis comes from the serology. The serology is the blood work. When we draw a hepatitis panel, we are looking for the presence of antigens and antibodies. This particular slide is for hepatitis B. Acute infection is going to have a positive HBsAg. That means hepatitis B, the little s is surface antigen. If it is positive, there is active acute infection. Look at the end to HBsAg, hepatitis B surface antibody. When that is positive, that means the infection has resolved. Now, those are the 2 easiest things to understand. If I have a positive HBsAg, I've got it. If I have a positive surface antibody, I'm over it. But in the middle is what we call anti-HBc, or the antibody to the core of this viral package. Okay, so there are 2 things we look at for this anti-HBc. One is immunoglobulin M and immunoglobulin G. Immunoglobulins are those things that help us fight infection. The presence of immunoglobulin M means the virus is on the move in the body. You got it. The presence of an anti-HBc IgG means the infection is gone. G means gone. And so you can see that there are times here when a person has active infection that the HBsAg is positive and the anti-HBc IgM is positive. The virus is on the move in the body, and the antibody is negative. Then you can see the infection is resolved. The HBsAg, the surface antigen, is negative. the IgG is positive, the virus is gone, and they have converted to an antibody, positive antibody against hepatitis B. The flip side of this is that a person can remain chronically infected. The antigen remains positive, and the anti-HBC IgG is also positive. So although the virus is not active, they still have a chronic infection. Their HBsAg is positive, and that means that they are chronically infected and have not developed an antibody. So you're going to see people who are vaccinated, and those that are vaccinated will have a negative antigen and a negative anti-HBC. They'll have a positive antibody. A person who's susceptible, and this is, you know this from your own vaccinations and looking at your records, that a person who is susceptible has no antigen, they have no core antibody, and they have no surface antibody. Okay. Serology for hepatitis C virus is a little bit different. The presence of an antibody for hepatitis C means there is active hepatitis C infection. Note the difference in the presence of antibodies for hepatitis B and for hepatitis C. An antibody for hepatitis B means the person's in recovery or is immune. And an antibody, a positive antibody for hepatitis C means the person has an active infection. It can be a little confusing. In your differential diagnosis, you need to consider hepatitis and other diseases that can affect the liver, such as mononucleosis, cytomegalovirus, herpes simplex, as well as drugs or toxins that cause liver damage. The management of hepatitis is focused on prevention. Vaccines exist for hepatitis A and for hepatitis B. Anybody that is going to be traveling into countries where hepatitis A is endemic can get vaccinated. All newborns at birth, at 1 month, and at 6 months are now vaccinated for HBV. Persons who are infected with HCV and those that develop chronic HBV can be cured or achieve remission through antiretroviral drugs or antiviral drugs for HCV and interferon nucleotides and nucleotide analogs for HBV. Anybody that you come across in your practice that has hepatitis C and or chronic hepatitis B needs to be referred to a hepatologist. Usually that's a gastroenterologist for treatment. Treatment is available. Chronic hepatitis B has consequences. Untreated chronic hepatitis B can lead to hepatocellular carcinoma. Untreated hepatitis C causes chronic hepatitis and liver damage that can require transplantation. In fact, chronic hepatitis C is the most common reason for liver transplant in the United States. This section is about appendicitis. Appendicitis is the most common cause of acute abdominal pain. Appendicitis is inflammation of the appendix. The pathophysiology involves the dilation of the appendix followed by an obstruction by hardened feces, which we call a fecalith, or from inflammation by pathogens, strictures, cancers, or foreign bodies such as a piece of food or seed, vegetable, that type of matter. The most common occurrence is between ages 10 and 30. It's high in the Western countries because of our diet that is low in fiber, high in carbohydrates, and refined sugars. There's a classic migration of pain from periumbilical to the right lower quadrant. Acute appendicitis is uncomplicated if the appendix has not ruptured. A rupture of the appendix causes peritonitis or an infection of the abdomen. This can also be a localized infection as a pocket of pus or an abscess in the abdomen. A note about the history. History is always subjective. It is what you ask and what the patient answers, or anything the patient tells you. The acute onset of mild to severe colicky, epigastric, or periumbilical pain is pretty classic. The pain, however, begins to localize to the right lower quadrant within 24 hours. Anything that jars the abdomen, walking, coughing, makes it worse. Often these patients are going to sit very still. That's because of peritoneal irritation. In men, there may be radiation to the testicles. You may have a presentation of spasms in the abdomen. This is called tenesmus, and this is usually a later sign that accompanies severe peritonitis. A couple of pearls for you. The nausea and vomiting usually come after the pain starts, not before the pain. Some of your patients are going to complain of diarrhea and others of constipation. There may be a mild temperature elevation. If anybody presents with rigors, which is shaking, suspect a perforation of the appendix. This is a picture of the migratory pattern for appendicitis. You can see that the early begins in the periumbilical and begins to migrate to the focal right lower quadrant. In late stages, this is usually with a perforation, there can be widespread abdominal pain because of the perforation and peritonitis. The physical exam begins with looking at the person. They may look sick depending on how the appendix is, whether if it's intact and it's inflamed, they may not look as sick as somebody whose appendix has ruptured and they're in severe pain. Vital signs, they may have some fever. They may also be hypertensive because of pain. You may see them if they're lying on their backs with their knees flexed in order to relieve the pain in their abdomen. Guarding is a voluntary tensing of the abdominal muscles. This is in anticipation of the exam. On the other hand, rigidity, abdominal rigidity, is an involuntary tensing of the abdominal muscles. This is a protective mechanism of the body. Abdominal muscles tense in order to protect the organs below. Rebound tenderness is a key sign. When you check for rebound tenderness, you're going to press into the right abdomen until the person kind of gets used to it, and then you pull your hand quickly away, and if there's tenderness, that is indicative of some sort of peritoneal irritation. You're going to use advanced assessment techniques here. This is a good time to review them. The Rovsing sign, which is deep palpation over the left lower quadrant. When you release that pressure, it causes tenderness in the right lower quadrant. Another is the psoas sign. With the person lying on their backs, you will lift their right leg straight up while applying kind of gentle counter pressure. If they have pain in the right lower quadrant, they're going to holler. Same thing, you can roll them on their left side and take their straight right leg back towards their bottoms. That's going to cause pain if there is inflammation in that right lower quadrant. This is a good graphic of signs of appendicitis using the different signs and advanced assessment techniques. Rovsing sign, McBurney's point, psoas sign, the obturator sign. Differentials for abdominal pain can be broad, and they can include sexually transmitted diseases such as pelvic inflammatory disease, but also inflammatory diseases of the bowels such as Crohn's disease, ulcerative colitis, and diverticulitis. That's why your history and physical are so important. Many GI disorders have symptoms that mimic appendicitis. Diagnostics for appendicitis include a CBC, in women a urine HCG for pregnancy, and plain film of an abdomen that may show a fecalith. A word about the CBC. We may have a mild to moderate leukocytosis. That's a white blood count between 10 and 20,000 micrograms per liter. And you may see a shift to the left. This has to do with the physiological production of white blood cells from the bone marrow. As white blood cells progress, they move from left to right, from immature to mature. And so if you see a shift to the left, you're seeing immature white blood cells. And when they increase, we suspect infection. These are two examples of some imaging that can be used to help in identifying a diagnosis of appendicitis. On the left is the KUB, or this is a plain film. This is an X-ray of the abdomen, and you can see the object the arrow points to. That's a fecalith, a hardened piece of feces that is blocking the appendix. On the right is probably the more standardized tool, and that's the CT of the abdomen. The CT is useful in that it can also identify the fecalith, but it can also determine whether perforation or development of an abscess in the abdomen has occurred. An ultrasound is often used and can visualize an inflamed appendix. In the United States, the CT scan is usually the test that's ordered. The most common treatment for acute appendicitis is laparoscopic appendectomy. There is an alternative for adults, less commonly with children, who have an uncomplicated acute appendicitis, and that is, rather than surgery, a 10-day course of broad-spectrum antibiotics. Now, appendicitis can recur in some of those people, usually from 1 to 15%. In a person with a complicated appendicitis, someone who has a perforation or is a surgical risk, the choice to do surgery depends on the size of the perforation. Think of the perforation as causing an abscess. That's a pocket of pus in the abdomen. If the pocket of pus is fairly small, less than 3 centimeters, the person would receive IV antibiotics and an appendectomy. If it's larger than 3 centimeters, or the person is quite sick, they're going to receive IV antibiotics, and there will be an attempt to drain the pus first. Often these patients are treated for 10 days in the hospital. They're discharged on oral antibiotics, and they may get an appendectomy about 6 to 8 weeks later. This actually happened to a friend of mine's brother who was quite sick from perforated appendix. There is a great reluctance to open the abdomen in someone that's got an abdomen full of infection. If they can contain it, treat it, drain it, and then remove the appendix when the person is healthier, then the complication rate is less.